Now please welcome back Bob Cusack, who will be joined by 4 very important voices on this topic to discuss the path forward on lowering drug costs and what's next to expect from PBM reform. Anthony Ciaccia, president of 3 Axios Advisors. Dr. Mariana Socal, associate scientist at the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. Amy Hinojosa, president and CEO of MANA, and James Gelfand, president and CEO of ERISA Industry Committees. Welcome, everyone. I hope I got that.
Thank you, Sarah. Why don't we go down the lines, James, starting with you, if you can briefly kind of introduce yourself, your affiliation, and your passion for this space.
Sure. James Gelfand with the ERISA Industry Committee, or ERIC for short. We represent the large employers who provide benefits to their workers and to the families of their workers. These are companies that make widgets. They are not health insurance companies, but they have to run these plans. And they tend to contribute about 75 to 80% of the costs of health insurance on behalf of the people who work for us and their families. So we hire PBMs to help us run those plans. We can't be negotiating with hundreds of pharma companies every year and trying to track the fluctuation of those prices. And the understanding is that they would work for us, and they would help us to achieve affordable coverage for our employees. But what we're increasingly finding is that there's a conflict there, and it's not working the way that it's supposed to work. Part of that is because while an employer is a fiduciary to their health plan, and we have to do right by the people in that plan, our vendors don't share that responsibility, meaning that they're there to make money for their stockholders, not necessarily to get cheap drugs for the employees. They're taking money from both sides as well. So at the same time they're supposed to be negotiating against Big Pharma, they're charging big fees to Big Pharma. Fees for things like the privilege to negotiate or to be stocked at a given specialty pharmacy, which the PBMs also own. And what we're finding is that change needs to take place in order for us to get health insurance costs and prescription drug costs under control. And to say that we need to make change to PBMs does not mean that there's no change needed for the drug companies, right? We still believe that major changes are needed for patents and at the FDA too. But you've got to take these things on one at a time or you're going to get nowhere. We're also, big believers in the free market. We know that free markets will help to drive down costs and get the most efficient products to our employees at the best prices. But when you have 3 companies that control 90% of a market, that's not a free market. That's an oligopoly. And so that's where we need government to step in and say, we're going to set some rules of the road to make this work. And if you don't believe that it's not working, all you need to look at is the biosimilars that came online for Humira. This is the highest grossing drug ever. The very day that a single competitor to that drug came on the market, you should have seen massive change. But what did you see? Someone can correct me on the panel, I'm sure, but I think it's about 2% market share has gone to those biosimilars. And the other 98% is staying with the super high cost drug. Why? Well, because the vendors who are setting these formularies and who are deciding who gets steered to what drugs, they want the higher cost drugs. So there's something that's broken here, and the employers are dedicated to trying to fix it.
Well, we'll talk about what's broken.
Hi, everyone. Amy Hinojosa. I'm the president and CEO of MANA, a national Latina organization. We're the oldest and largest Hispanic women's organization in the country with chapters and affiliates across the nation who focus on strengthening Latinas through mentorship, education, and advocacy. We're also a founding member of the Health Equity Collaborative, which is a collaborative of 50 national organizations focused on uplifting principles of health equity, among them costs, right? And one of the things that we've taken on, and this collaborative isn't just a Latino collaborative, it goes across all spectrums of underserved and unserved voices, including African American, AAPI, LGBTQ, patients' rights organizations, chambers of commerce, and really the way we see it is how can we uplift all of our underserved communities in this conversation about health equity. And PBM reform comes right to the top of the list because lowering costs for average Americans is really at top of mind for everyone, especially as we live in this inflationary market and figuring out how folks are making ends meet, right? And the figuring out, I get asked all the time why Latinas care. 1 in 5 women in the United States today is Latina. By 2060, that number will be 1 in 3. We also have the highest rates of, among the highest rates of obesity, heart health problems, diabetes, And so when you talk about the impact on the average person in community, figuring out how they're going to pay for their healthcare costs, including their medications, Latinas only make 52 cents on the dollar for what a white male earns. Thinking about how they make those ends meet under those circumstances, and then figuring out how, under these inflationary prices and the charges that are being given to them when they go to the pharmacy, figuring that out is of the utmost concern. And so that's how we come to the table, to the conversation, but then figuring out how we look at what's going on in the ecosystem for where the changes are made. Because if someone's being pinched in terms of a cost, someone else is making money. And we want to make sure that we're pinpointing and spotlighting who's doing that so that our folks can make sure that they're able to afford what they need to survive.
Mm-hmm. Mariana?
Hi, everyone. It's a great pleasure to be here. I'm Mariana Socal. I'm a physician. I'm a faculty at Johns Hopkins University. And all that I do, day in, day out, is to research the pharmaceutical market in the US and how to make drugs more accessible, more affordable to the American people. I mean, as a physician, you know, I'm sure I don't need to tell you that pharmaceuticals are crucial to increase the quality of life of individuals, to expand survival, to prevent disease, to prevent complications. So it is on everyone's best interest that drugs are available. But in this country, my research has found that we do pay, on average, 3 to 4 times more, highest prices than other similar developed countries such as, UK, Japan, Canada, and others. So the question is why? We are the #1 country in terms of research and development for drugs. We have many, many hundreds of new drugs coming into the marketplace every single year. And my research has found that, often we hear people saying, well, we don't really pay these high prices for these drugs. The insurers that we hire to represent us in the pharmaceutical market, they are getting better deals. They are getting lower prices. But that's just partially true. My research has found that when individuals pay, for their prescription drugs, whenever they pay cash because their plan doesn't cover the drug, or whenever they pay a deductible because they have a high deductible health plan, or a co-insurance, a percentage, they go to the pharmacy and they're required to pay a percentage of the drug cost. In none of these situations, these individuals benefit from the discounts and rebates and everything that is paid, that is negotiated on their behalf by their insurers. So, patients being always faced with these very, very high prices that nobody else in the world is paying, that's the reason why, often people with very generous insurance still cannot afford their drugs. I've also worked with employers, for example, self-insured employers, and in my research, I have never found a single employer that wants to restrict benefits to their members. Everybody wants their members to have the best benefit. But then the question is, at what cost, And it turns out, in this country, it is the drug manufacturer that does set the drug's price. That's the, responsibility of the drug manufacturer. Whenever they launch a drug, whenever they commercialize a drug, they can decide how much they want to charge for the drug. They can also decide how much they want to provide in terms of rebates and discounts, and they do so by negotiating, with insurers and on their behalf, the pharmacy benefit managers, to get their drug covered. So we've seen in conversations over and over and over, drug manufacturers saying, I cannot lower the price of my drug. That's why prices are high. Because if I do lower my price, the pharmacy benefit managers and these intermediaries cannot make as much as a profit on my drug. That's the case of Humira that Jim very well brought up, And then my drug will not be covered. Humira biosimilars are a good example, right? But my research found that even when we take away, these incentives, these profits that can be made, it's not only about doing savings from not having these profits. It's also about removing the incentive to have a preference for higher cost drugs. So we have hundreds and hundreds of options in the marketplace, but often we see the PBM choosing exactly Humira, exactly the most expensive. We found that by changing these incentives, employers could save, net of all rebates and discounts, between 9 and 15% of the per member per month spending. So the opportunity for real change here is possible. it does depend on changing incentives, but that does have effect, on the end user, which I think is who the person that we most care about is the patients who need these drugs to survive.
Mm-hmm. Tony.
My name is Antonio Ciaccia. I'm the president of 3 Axis Advisors and the CEO of a nonprofit organization called 46 Brooklyn Research. I'm a drug pricing nerd from Ohio. I came from the pharmacy world, very perplexed at how the flow of dollars works in the prescription drug supply chain. And to make a very long story short, what we were seeing in the state of Ohio was that pharmacies were getting paid less and less for the medicines that they were dispensing to their Medicaid beneficiaries. But on the other end of the transaction, as those cuts were occurring, the state of Ohio was spending more for their medicines through the Medicaid program. So those two things didn't make sense. How could providers be getting paid less, but the state who's cutting the checks on the other end of the transaction be getting charged more? So we started downloading very boring Excel files off the CMS website and stitching them together to demonstrate that despite the black box of drug pricing, there is enough publicly available information to start providing directional insights. So we started charting all these things together and found a growing gap that existed between the underlying costs of medicines, what pharmacies were being paid, and what the state of Ohio was being charged. We took all of that data and decided to publish it online for free and sat down with investigative journalists at Bloomberg News and the Columbus Dispatch, and it started a cascade of events and dominoes falling, where our state auditor decided to open the books and find that the growing gap that we had identified was worth $245 million in just 1 year of our Medicaid managed care program. What was happening was that PBMs were engaging in a practice called spread pricing, paying pharmacies low, billing the state high, and pocketing the non-transparent difference. What we learned is that, hey, maybe we could save some money with that $245 million. And what we learned is that spread pricing is just one way that PBMs make money and ultimately distort the prices of medicines that we pay as plan sponsors if you're an employer or patients as a consumer.
Regarding that on spread pricing, what about, as you said, PBMs have a lot of ways to make money. They're talking to the congressman about how having to put in the legislation very detailed so we're not playing whack-a-mole. Do you think that the current bills, and there are plenty of them, one has passed the House overwhelmingly, will do the trick? And will those savings actually go to the consumer?
I would hesitate to make it so black and white to say this will fix the problem,
okay,
because there is a multitude of problems, and those problems all range in terms of severity. So, as an example, in Ohio, after they banned spread pricing, again, the difference between what's paid to a pharmacy and then what's billed to the plan sponsor, the state said, hey, that's a lot of money, we're prohibiting that practice. Well, the stocks of the large PBMs never took a hit. What happened was they reacted to the change in policy by overpaying the pharmacy at the point of sale, essentially building up an excess relative to the guarantee that the PBM had to pay to them, building up that excess that could be then clawed back later and then never disclosed back to the state. Furthermore, the other tactic that arose was this practice of specialty pharmacy overcharging and steering. When we talk about PBMs, we ultimately do a disservice to characterize them as standalone entities. PBMs are large, vertically integrated companies that own health insurance lines of business, specialty pharmacies, mail-order pharmacies, retail pharmacies. So if you're a PBM and you're setting the prices of drugs that are dispensed at pharmacies, well, good news, you get to set the prices of drugs that are dispensed at pharmacies you own and the pharmacies that pharmacy competes with. So what happened was that PBM started overpaying for a number of specialty products that they get to determine that the patient has to get at the pharmacy they own. So I say all of this because just when you think you have the answers, expect that they will change the questions. So policy ultimately is going to be an endeavor in chasing the games and minimizing the perverse incentives for PBMs to act against the interests of their clients.
Mm-hmm. Mariana, you mentioned other countries. What can we learn from other countries? America is very focused on America, but where are there models out there that it would be good for policymakers to possibly mimic?
Well, I think the number one question is how much does a drug cost in the United States? Go to a pharmacy. Good luck figuring that out, right?
Right.
Because the system, there is a benefit from the system not being transparent. All these layers of negotiation and invoices and contracts and, all these accounting exercises, they provide a service. And the service here is non-transparency, allowing these profits to be made, allowing, these clawbacks to be made, and these dollars to kind of, go to hands that not always have done the best service to the end user. So I think the number one question here is, we talked about, for example, delinking, PBM compensation from the prices and the negotiations they provide. That's linking all of these things together. Whenever you can benefit from changing prices, of course, prices will continue to be changed, and pricing metrics will always be non-transparent. There's a company that I've worked with in my research, and it's really interesting. They're a self-insured employer. They produce software. It's a software you can use for many things, but one of the uses you can have is to manage claims, for example. You can use that software for, for these environments. When this company talked to their own PBM to say, hey, how much am I spending on drug X? The PBM said, you need to pay me $5,000 so I can tell you. Because that's not part of our contract that I need to tell you at any point in time. I'm due to tell you at this time and only in aggregate with another, drugs in the same therapeutic class. So that's the kind of transparency that we need, and transparency that is based on, more symmetry between PBMs and the companies that hire them. Today, we only have the three largest PBMs. They really concentrate about 80% of the market. So imagine a self-insured employer that is operating, somewhere out there, and they're, really focused on doing the service they're there to do, the company, right? How can they, in good faith, negotiate with one of the largest three PBMs in the country, How can they negotiate? How can they, get a good deal? It's often the case that PBMs say, oh yeah, you're getting the best deal, but how do you even know when there's no transparency?
Amy, as far as the Latina community, the cost of prescription drugs is not a new issue. When I came to Washington, Bill Clinton was president, and he talked about it. We're going to be talking about it for decades. Do you see improvement, big picture, if you pull back? We've had the Inflation Reduction Act. We've had policymakers trying to attack this problem for the longest time. But here we are still talking about the high prices of prescription drugs and what to do with it.
We are still talking about it, and I think that, as we're talking about the transparency of it all, that's what's keeping us from getting to the solution, right? Is that there are, backdoor deals, if you will, being done to increase profits on the PBM side, on the insurer side, and consumers are the ones who pay the price all the time. What sort of the undercurrent of what we're talking about here is that when someone goes to the pharmacy and tries to get the prescription that their doctor prescribed, they're not able to get it if it's not one of the available medications that have been, that the deal was cut for, right? And so change has to come when the doctor who's responsible for your care can prescribe the medication that you need to save your life, not what someone else decides because it's going to increase their profit margins, right? And then how it bleeds into other systems. For example, with the IRA and with so much other legislation, we advocated for the 340B program, right? And making sure that funding goes into community health centers and smaller organizations that are providing care on the ground to the poorest and the most indigent, the ones who are in the most need. What we're finding is that the PBM intervention is also taking that away. And so we as community advocates have to make sure that our community is being served the way we told them we were advocating for, right? So it almost makes us look like we're part of the problem as advocates when we were advocating for the money to go into community, and now we need to make sure it gets there, right? So what we're talking about really are guardrails, right? We know that these are large systems that have to be negotiated over the entirety of the system, but we need to make sure that the patient, the consumer, is centered in the conversation, because we can talk all around all these issues, but if at the end of the day a person who's sick can't get their medication, we failed.
James, a two-part question for you. Number one, the Brookings Institute did an analysis of PBM reform, and they had a couple findings, basically. One of them was the promises of PBM reform may be overstated. Number two, there's a lot of, there are so many big players in the PBM industry and that is a just criticism of the industry. Can you respond to that? And then the second part of the question is, can you explain how PBMs and employers, the rules that are different for PBMs and employers? Because that's a complicated world.
Sure. I think details matter. So if you're talking about PBM reform, it can mean a lot of different things if you talk to different people. The bill that moved through the House of Representatives doesn't change the way that PBMs do business. It doesn't change anything in terms of the private sector. They'll just send you a report so you can learn about how much money you just wasted on expensive drugs. Now in the Senate, a number of bills have moved through committee that would actually change the way that those companies do business. And we believe we would see massive savings, and patients would see massive savings on their drugs if those Senate provisions do become law, and we hope that some of them will. Right now, though, many who are studying this are looking at the campaigns that are taking place. They're seeing that a number of former representatives and senators have started writing op-eds about how changing anything about the PBMs will be the end of the world. You'll lose access to your drugs. Your grandma's going to have to eat cat food. Now, hopefully, most in Congress can see through that this is a $15 million campaign that's been going on, and that they do need to make some change. That being said, some things were seen as so complicated that they didn't get included in the legislation. And one of those would be aligning the rules between an employer and a PBM. So your employer, as a fiduciary under the Employee Retirement Income Security Act of 1974, has to be a good steward of the money that gets spent on your health benefits. They can't keep it for themselves. They can't pay excess amounts of money that don't make sense to pay. They have to try to do right by the plan beneficiaries. We said, hey, that's a pretty good set of rules. Maybe we should apply those same rules to the PBM. But the PBM said, well, if you apply those rules to us, our business model will have to change. Like, yeah, that was the idea, that was the plan. But unfortunately, I think in Congress, that was seen as maybe a little bit more complicated than they were ready to do at this time. So for now, step one is try to move those key provisions that have been moving in the Senate. So some are calling it delinking, but the idea is changing the incentives there so that PBMs, instead of trying to make money through arbitrage, they're trying to make money by saving money. That's what you want the PBMs to be doing. And we think transparency is an important part of that. You got to address spread pricing. You got to address the rebates. You got to address these offshore GPOs in Switzerland and Ireland. You've got to do something about the fees that they're charging the pharma companies to participate in your formulary. And you got to get those formularies to make some sense. If you do those things, you're going to start to see change taking place.
As far as, Amy, go to you on this, as far as what, we talk about a lot of acronyms and the House and Senate bills, and those details are very important, and the implementation of legislation is, I think, underrated. But what's your advice to people who are watching this that are struggling to understand it, and they're just struggling with their bills and inflation, and specifically on drug costs?
Yeah, I think that the first thing is to tell people you're not mad at who you think you're mad at.
What do you mean?
Because I think that it's very easy to just say big pharma is the source of all of our problems, right? And that would be a very easy answer, right? And we can talk about list pricing and how all that's done. But it's this other ecosystem that's occurring, and it's causing these impacts that impact their pocketbooks, right? And so understanding that there's an ecosystem that's taking the rebates that are meant for them, that's taking profits from something that could benefit them. I mean, really, changing this model could put money back in the pockets of people immediately. And so part of I think personally why we haven't been able to get over the line on some of this legislation, right? We've had some great proposals, right? Congressman Auchincloss talked about the latest one, the Drug Act, right? And you have the Pharmacy Benefit Manager Reform Act, the Help Co-Pays Act, the Lower Cost, More Transparency Package. All these things are coming to the table, and they have bipartisan support. But what it doesn't have is the support from the community, right? There has to be a groundswell of interest from people in community saying, this is important to me, this could change my life.
Because that will get it over the hump.
That would get it over the hump.
Got a couple of minutes left. Antonio, go to you for maybe closing remarks, if you can keep to a minute.
I mean, ultimately, when people are sitting around their kitchen table saying, talking about affordability, they're not saying, what are the PBMs up to now, right? Of course not. They're sitting there saying, how do I afford my medicines? Conversely, employers are sitting there asking the same questions. How can we continue to provide benefits in a system where the vendor's incentives are in direct conflict with that of the plan sponsor and the patient? The theme here is transparency. The joke, is that you go to a CVS pharmacy and buy a stick of gum, you're going to get a receipt that's a mile long.
Right.
Well, if you spend $1 billion on medicines, CVS will be happy to give you a one-page, one-sided PDF file that says, hey, here's the top 50 drugs that you spent money on. That's not transparency, right? Part of the reason you're seeing this reckoning is because you have people like Mark Cuban's Cost Plus Drug Company that's saying, hey, these prices that you're being charged are bogus and way overinflated, and I'm going to show you my prices online. You can download them at any time. That is creating a reckoning in this industry, and I think that transparency is a very healthy disinfectant.
Mariana, I'll give you the last word, just 30 seconds if you can.
Well, whenever I'm teaching about this topic, people always get surprised that the PBM designs the formulary, but if things go wrong, patients cannot get the drug and go to the hospital, there's no penalty to the PBM. The insurer will bear the cost, the patient will bear the health costs, but the PBM, they got the money and, they did their job. So I agree with this fiduciary responsibility, here, who are we serving? If we're serving patients, that should be the important metric. How is access happening? How is our health changing? And, through all of these practices that we're talking here, I think that's not where we are today.
Great panel. Please thank them for joining us this morning. And I'll hand it back to Sarah. Thank you so much.